Today I am presenting two challenging cases that we've had in the last 6 to 8 months. So one is a case of carcinoma of the thyroid gland, and the another one is a case of parathyroid gland. This is, I would say, this is not something heroic that we have done surgically. It's a regular process for oncosurgeons to be handling such cases. But the more important point I want to highlight here is the magic of teamwork and how various new diagnostic modalities and therapeutics, when they come together in oncology, how they change the patient outcomes, and we'll come see in the coming slides. So the first case is a case of thyroid carcinoma. So this is a 45-year-old lady who came to me around last year in June, somewhere in June. She came with a history of having underwent a hemithyroidectomy somewhere in Varanasi in 2018. There was no histopathology record of the same. The patient said that it wasn't sent for a histopathological examination. Now she came with a few complaints, like her neck was all studded with multiple swellings in front and side of the neck for the last 3 months. She was complaining of tingling and numbness in both hands, recent change in voice, pain in the cervical spine area, a difficulty in swallowing. Nutritionally and ECOG wise, she was well preserved. So this is how she presented to us. She also had a CT scan done, which you can see. The bilateral neck was all studded with such tumors on either side of the trachea, and you could also see that here there was a destruction of the vertebra. So this is how she came. Uh, yeah. So this is her CT scan report, which said that she has a destruction of the C2, C3 C4 vertebra, with the complete collapse of the C4 vertebral body and posterior cortical bulging with compression upon the cervical cord. So the symptoms of tingling and numbness were basically attributed to this. I got a biopsy done of the swelling. It was suggestive of a follicular variant of the papillary carcinoma of the thyroid. So the next thing was, how do we do it? Because she has a unstable cervical spine with tingling and numbness of the hands, and she has a thyroid carcinoma. Because she had only undergone a hemithyroidectomy, the half of the thyroid was still intact. So in the coming slides, I'll tell you how it became a challenge for us. So what were the options before us? The options were: do we straight away go for the surgery for the thyroid gland? It was an extensive disease which was extending posteriorly, as you can see, across the prevertebral fascia and damaging the cervical spine. Next option was either we go for the surgery for the spine first and then the thyroid, or radiation to the spine and then look for surgery, or radioactive iodine therapy that is usually given in a papillary or a follicular thyroid carcinoma. And most importantly, to decide the intent of treatment, whether it is curative or palliative. So as is the usual process, we discussed it in our tumor board. And the few points that were discussed was, firstly, the patient has an unstable cervical spine. She's having tingling and numbness of the hands. And with such a spine, any bending, because a thyroid surgery would require a good extension of the neck, that would cause even more pressure on the cervical cord spine. So that was one issue that was discussed. So the patient cannot be kept in extension for the thyroid surgery. That was a very important thing that was discussed, because we involved not only the radiation and the medical oncologist and the surgical oncologist, we also had our neurosurgeon on board to discuss this issue. Secondly, it was a very highly vascular tumor, and because the spine, if at all we were considering that the spine surgery was required, she needed to be in a prone position. For the thyroid surgery, we needed a supine position. So there was only, it was not like we could do both the surgeries at the same time by fixing the spine and then turning her. So it was a vascular tumor requiring prone position for spine surgery and destroyed pedicles on one side. So another the options that we have for a papillary thyroid carcinoma usually If we have done away with the thyroid gland completely, that is, we have removed the complete thyroid gland, then papillary thyroid carcinoma responds very well to radioactive iodine. But in this case, since only half of the thyroid gland was removed, the challenge was, unless and until we are able to remove the complete thyroid gland, we will not be able to give her radioactive iodine therapy. So uh, the decision was, first, to be able to bring out the complete thyroid, we need a cervical spine which is stable. So it was decided that first we need to do something for the spine. So the decision was, let's try and give her 5 fractions of radiation, so that the cervical spine, at least the edema which it is causing, that would be reduced. So we started her on steroids and started her radiation. It was just planned for 5 fractions of radiation. She started her radiation on steroids. She was staying very close by to the hospital. She had come all the way from Varanasi. She was staying just 2 houses away from Max Vaishali. Suddenly on day 3, when she was supposed to come for her radiation, I get a call from the patient attendant, her husband, who says that she is suddenly fallen on the floor in the washroom and we need some urgent care. Uh, because we are fully equipped, Max Vaishali, we called up the guys, they rushed the ambulance to the residence, the patient was brought to the hospital. What happened was, basically she had further edema of the spine due to radiation, which caused the fall, and she was unable to get up from the washroom. So this led to quadriparesis. The question was whether it was a radiation induced cord edema. We again sat down. We decided that the radiation needs to be stopped immediately. The neurosurgeon got on board and he said, let's just fix the spine first, because without that we are not going anywhere. So the patient was first planned for the cervical spine surgery. They went ahead in a prone position, removing whatever they could posteriorly with all the vascular tumor that they had. They were able to somehow fix it on one side to make the spine stable, and they advised that she needs 6 weeks of immobilization with a cervical brace. Patient stayed back here with the cervical brace. She was in Delhi. Uh, then, after the clearance from this neurosurgeon, after 6 weeks, we went ahead and did the completion thyroidectomy, total completion thyroidectomy with central compartment clearance and the bilateral nodes. All that we could see on the CT scan, we were thankfully able to complete it. So this is how she looked. All this that you see here, uh, all this and on this side was the complete tumor extending up to the suprasternal notch and behind it. Thankfully, we were able to remove all of it. Final histopathology showed papillary thyroid carcinoma. Out of the 84 lymph nodes that we removed, 23 were positive for cancer and had extranodal extension. So as is the norm in such cases, because we are planning for radioactive iodine therapy, we put the patient on thyroid suppression. That is, we did not give her thyroid replacement even after doing the complete thyroidectomy. We got a radioactive iodine scan done after 6 weeks, which was suggestive of lot of tumor still there in the neck because of the posterior extension to the spine. She then received 100 millicuries of radioactive iodine therapy, and thankfully after 3 months of the completion of the treatment, when in June we got her radioactive iodine scan done, uh, first most important thing was she came into the room walking completely stable, with all the complaints of tingling, numbness and not being able to walk, or change in voice. All that had disappeared. She came into the room walking with her radioactive iodine scan, which was normal. Currently, till the last follow-up, which was in November, she is symptom-free and carrying out all activities of daily living. So the few questions that I said came to mind in this question, in this case, was most importantly was that decision of the tumor board of going ahead with the radiation first. Did it cause a catastrophe of radiation-induced edema leading to her fall? Uh, we still don't have an answer to it, because we had started the patient on steroids, but that is again something to ponder upon. Could we have done the thyroid surgery straight away? That was anyways not a question. Obviously the spine was unstable to go ahead with this thyroid surgery. Could the spine have been managed without surgery? No, not at all. Definitely it needed all this. So take home from this case was thyroid malignancies, although most commonly managed with surgery followed by radioactive and iodine therapy, can sometimes present with challenging scenarios such as this. And most importantly, uh, any specimen that we take out, like this patient had undergone a hemithyroidectomy in 2018, if she had a histopathology report with her, she would have been treated completely at that time and we wouldn't have landed in such a scenario. So always sending a surgical specimen, even though we are sure that it's a benign, we still should send it for histopathological examination. And the patient, there are times, there are a lot of patients undergo a cholecystectomy. Lap cholecystectomy is such a common procedure that a lot of patients who come from peripheries, they don't have any histopathology report saying that sir gallbladder tha nikal diya, we don't have, and they come back after a year with someone having a port site metastasis, someone having gross lymph nodal disease. So the most important point, they don't have any histopathology report. So any specimen, irrespective of whatever we are thinking, should and must be sent for a histopathological examination. And as I said, multimodality management in such patients gives the best clinical outcomes. Coming to my case number 2, this is again an interesting case who was a 70-year-old lady. She was admitted to another private hospital with very vague symptoms of weakness, urinary tract infection, fever, and walking difficulty. Her workup that was done in that hospital showed raised serum creatinine of 4.3, serum calcium was 13.4, and her parathyroid hormone level was 1083. The attendants had come to me first. They said, sir, हॉस्पिटल में उन्होंने कुछ एक कैल्शियम कम करने का इंजेक्शन दिया है कल, बाकी तो कुछ पता नहीं है, और एक पेट सीटी कराया है. So the PET CT showed a mildly FDG avid hypodense nodule in relation and inseparable from the inferior pore of the left lobe of the thyroid gland. So that is a usual position where we have the inferior parathyroid gland. Plus, she had a FDG avid right, so it was a left side inferior parathyroid gland with a FDG avid right supraclavicular lymph node. Again, the SUV was much higher. The SUV here, as you see, the lymph nodal, the right supraclavicular lymph node SUV was 9.5, whereas the SUV of the nodule in relation to the thyroid gland was much less, which was 1.6. So this was her report. She also had an ultrasound report with her, which was again showing that she also has a multinodular goiter in her left lobe of the thyroid gland, where the nodule of that parathyroid gland was situated. So a parathyroid scan was also done over there, which showed that it could be a possible left lower parathyroid adenoma in view of the raised serum calcium, renal injury, and raised PTH levels, which were 1083. So this was her parathyroid scan in relation to this inferior lobe of the thyroid gland. It was showing this nodule, which could possibly be a parathyroid adenoma. We got this PET CT and the parathyroid scan reviewed at Max Vaishali, but our nuclear medicine experts were of the opinion that this doesn't look like a classical adenoma of the parathyroid gland. It should have shown shown much brighter on the parathyroid scan, so it doesn't look like a parathyroid adenoma for sure. We got the patient shifted to our hospital. We were managing it initially by medical conservative management. The serum calcium levels came down to 9.9. The PTH levels were 597, creatinine of 1.65. As I said, we got the scans reviewed. The question was the parathyroid, the hyperparathyroidism. So whether it's a primary or a secondary hyperparathyroidism, because if she is a patient of renal failure, it could very well lead to secondary hyperparathyroidism causing raised PTH levels, which correlates with her creatinine, with her serum calcium, and everything else. Or whether it could be a primary parathyroid adenoma or a parathyroid carcinoma. So we got a FNAC done from the nodule that was showing on the ultrasound from the parathyroid area. Again, the pathology was, the pathologist confused us more than what would have asked for. So adenoma could not be ruled out and required a clinical correlation. And we also got a FNAC done from the right supraclav node, which was negative for malignancy. So after all the medical management, since the patient was not improving, so right now we were in a situation where patient had a multinodular goiter of the left thyroid with a nodule posterior to the thyroid gland, which could possibly be something arising from the parathyroid gland, plus a right supraclavicular lymph node, which was negative for malignancy on an FNAC. Since the patient was not improving, patient was explained about anyway requiring a surgery because this is adenoma cannot be ruled out. It is showing up on the scan. We need to go ahead with the surgery. So surgery that I decided for this patient, to my good luck, I would say, was a left hemithyroidectomy with a parathyroid gland removal because she had a multinodular goiter in the left thyroid gland. So as is the norm in such cases, during the surgery, we do a intra-parathyroid hormone monitoring to see if the levels have been brought down to a sufficiently low level. Otherwise, we go for a 4-gland exploration wherein we examine all the 4 parathyroid glands to see whichever could have any other nodule or suspicious adenoma. So intra-op PTH monitoring was done at 5 minutes and 15 minutes as is usually done. So it kept falling sequentially from 128 to 88 at 5 and 15 minutes. Post-op period was uneventful. Now the interesting picture is the histopathology report now comes as, after ISC, as a parathyroid carcinoma, which is in fact a very, very rare malignancy. I don't know how many of you would have come across this malignancy in your practice, but it's a very rare cancer. So what initially was thought to be a very benign nodule, something adenoma, or maybe a secondary hyperparathyroidism due to CKD, all turns out to be a parathyroid carcinoma. Now, as I said, to my good luck, the surgery that was performed was a left hemithyroidectomy with a parathyroid gland removal. The treatment for a parathyroid carcinoma of the parathyroid gland is a hemithyroidectomy of that same side along with the parathyroid gland. I did not do this thyroidectomy actually because I was thinking in terms of carcinoma, but because of the multinodular goiter. We had a tumor board discussion as to what is the treatment next. As I said, the surgery was adequate because we have done away with the thyroid gland on that side. So it was decided that we keep the patient on follow-up with parathormone levels. So now the interesting part is after 4 weeks, the PTH which had fallen down to 88 comes to 388 after 4 weeks. What next? What do? We already had got a PET CT done. We got the parathyroid scan done. The levels had fallen sufficiently. Now we are in a fix that the PTH levels is rising again, and this time it's without any component of kidney injury. The serum calcium was around 10 or 11. The creatinine was normal. So we are very sure that it's not because of the renal thing that this is raised now. Now comes the real picture. As I said, the role of diagnostics. So what we got done before was a FDG PET CT scan, which is normally done these days for any cancer. But when we sat over it with all the nuclear medicine guys and discussed what could be done next, they said, you are dealing with a parathyroid cancer. The FDG, because as I said, the SUV of that parathyroid nodule at that time was 1.6. The supraclav was 9.5. So they said the FDG PET would not show the parathyroid as well as a choline PET CT would be done. Very frankly, we had not discussed choline PET CT before that. The choline PET CT even at our center is done once in a month because there are not too many cases who need a choline PET CT. Luckily, there was a choline PET that was scheduled another week later. So we advised the patient to undergo a choline PET CT. Now, this choline PET CT shows there are 2 lesions in the lung, highly suspicious of metastasis, and which are not amenable for either a biopsy or a FNAC. What do we do next? Again, the simple answer when you don't have an answer is sit in a tumor board and discuss things. So it was decided that since no FNAC can be done, they are deep-seated lesions, we cannot be doing any surgery for it. So what we decided was a very modern form of radiotherapy, which is a SBRT. So patient was advised that they undergo a SBRT. SBRT was done. It was done in around 2 or 3 sessions. And PTH levels after that came down to 58.4. This is, I'm talking about around 4 months back. Now the patient is on regular follow-up. She keeps sending me report of her PTH every month. Currently, it's at the level of 30 or 32. So patient is doing well. So all I wanted to highlight was how different modalities come together in oncology and can do unimaginable things. And we can sometimes be pleasantly surprised with what we do and what we see. Thank you.